So welcome back, everybody. We're on to week 4 of Cardio-ECHO Tackling Type 2 Diabetes series. I'm Jessie Lewis, the clinic coordinator. Dr. Dungan, you can take it away.
Good morning, everyone. I'm Kathleen Dungan. I'm an endocrinologist at The Ohio State University, and I will be facilitating this session as well as presenting your didactic today. I'd like to introduce Gautam Rao. Go ahead. Are you here, Gautam?
Yes, I am. Thank you, Kathleen. I'm Gautam Rao. I'm the director of the ECHO program.
So we'll catch up with Gautam later. He is the lead for the ECHO series overall for cardio. And our case presenter today will be Carrie Kales from Signature Health. And just as a friendly reminder, the structure of our ECHO clinics, as with the previous weeks, we will have a 25-minute or so didactic presentation followed by questions. And we'd like to encourage you once again to either use the chat box or please, even better, chime in with your video and your phone so that we could make this as interactive as possible. That will be followed by our case study, about 25 minutes with discussion. Once again, at the end, please, turn on your cameras at least so we can discuss that case. And then we'll have our wrap up. Next slide. These are our disclosure statements. Those were emailed to you on Tuesday. And this is our topic for the day. I will be discussing new and emerging therapies for type 2 diabetes. So these are our objectives. We're going to describe the role and benefits of the GLP-1s and SGLT2 inhibitors. We're going to describe current treatment recommendations for selection and titration of insulin therapy. And finally, we will discuss developments in technology for management of type 2 diabetes. So first off, let's put this into context. Why do we care about glucose control? Well, this goes back decades, several decades, in which we have had several attempts to examine what level of glucose control is needed to help improve long-term outcomes. And one of the first studies that was done, as you all well probably know, is the UK-PDS study. But then there have been several other large randomized controlled trials that have also attempted to assess whether even more tight glucose control might improve outcomes. This is very well established for microvascular disease, but not so well established for other outcomes like mortality and cardiovascular death. So on this slide, you can see the results of a meta-analysis that incorporated several of these long-term cardiovascular outcomes trials. In particular, on your left is all-cause mortality. In one of the trials, the ACCORD study, intensive glucose control was associated with an increase in risk of mortality. Now, this was not observed in the other studies. There are some differences in the types of patients that were enrolled. In particular, UK-PDS was newly diagnosed patients, whereas the others were much more advanced patients, most or at least the majority of whom received insulin therapy. And then cardiovascular death was really similar, although we did see perhaps slightly more in the VADT compared to all cause. So if we look at UK-PDS in particular, so this is newly diagnosed patients with diabetes, it turns out that there's a really interesting legacy effect. So early on, at 1997, after the randomized portion of the study was completed, you could clearly see reductions in any diabetes-related endpoint, and in particular, microvascular disease. But cardiovascular disease was of borderline significance. If you then follow these patients longitudinally in just an observational manner where we're not really aiming for any more glucose control than would be identified by the standards of care at the time, now you start to see differences that weren't observed in the first 5-10 years of follow-up. So the point is that it takes a long time to identify reductions in risk of mortality and myocardial infarction with more intensive glucose control. And so you really want to tailor your interventions to people who are actually going to benefit. Now, keep in mind that all of these studies were really done in an era before we've had these newer agents, or before they were widely used anyways. So what if we were able to do this in a more intelligent way, in a way that not only maybe lowers glucose, but has other cardiovascular benefits? And so similar studies have not been done with GLP-1s and SGLT2s, for example. And what's really important about these studies and about these drugs in particular is that they don't cause hypoglycemia. And it's thought that perhaps one of the reasons why there might be an increase in mortality if you really try to aim for tight glycemic control is due to this risk of severe hypoglycemia. So as you can see here, I've got a slide that's depicting the mechanisms of action for GLP-1 receptor agonists, which are shown in the green boxes, and for SGLT2 inhibitors, which are shown in the purple boxes. And then there is some shared mechanisms that are shown in the orangish boxes. So you can see there are some synergistic effects that might have some beneficial cardiovascular effects as well. There is a reduction in A1C, of course, but both of these drugs have additive effects on weight loss. They tend to both reduce blood pressure, although they are not considered antihypertensive medications, and they both tend to have lipid-lowering effects, if not only related to their weight loss. Neither cause hypoglycemia, and both have been identified to result in beneficial cardiovascular and/or renal outcomes, but the mechanism is probably a bit different. So for GLP-1s, we think this is a more long-term sort of atherosclerotic reduction mechanism that might be mediated by weight loss and some of these other mechanisms. For SGLT2 inhibitors, there might be some benefit from weight loss, but there's also felt to be changes in hemodynamic that are elicited by these medications, changes in plasma volume, renal blood flow, and fuel metabolism. And the effects on cardiovascular events are observed much more quickly than one would expect with GLP-1s. So the tantalizing thought might be that if you use both of these together, that you might also have additional or additive cardiovascular benefit. But we, in fact, don't have any evidence for that, or at least not substantial evidence that that is the case. So what is the evidence? Well, it turns out we have many cardiovascular outcomes trials. And for the purpose of this discussion, I have, for the most part, limited this to trials that have been done in patients with diabetes. So there are some trials that are being done in patients who have heart failure with or without diabetes and kidney disease, particularly with respect to the SGLT2 inhibitors. And there are trials that have been done for weight loss in the GLP-1s. So next, so this is the trials that have been done with DPP-4 inhibitors. I'll cut to the chase here. They're very large studies with some interesting designs. They are all neutral, so no risk in the major adverse cardiovascular endpoint of these studies, which varied perhaps a little bit. The one conclusion that we did, however, note in secondary safety analyses was that perhaps a couple of these medications, in particular saxagliptin, might have an increased risk in hospitalization for heart failure, and we don't know the mechanism for that. In terms of GLP-1s, in that orangish box, there have been at least 7 long-term cardiovascular outcomes trials. You can see the variety of agents that have been explored. They're very large studies. And next, what I've laid out for you in the box and those little plus signs is those are the trials that actually had beneficial MACE outcomes. So liraglutide, semaglutide, dulaglutide, and albiglutide. Now, oral semaglutide was not powered to show benefit, but there was a reduction in mortality. And the reason why I'm just highlighting sort of these outcomes among these trials in particular is that you'll note that why aren't they all the same? Isn't there a class effect? Well, we're actually not quite sure if there is a class effect. In particular, there were a lot of differences in study design and the populations of patients that were included. And so it's very difficult to say that it's not a class effect because of some of these differences in the trials themselves. And then finally, in the blue boxes is the SGLT2 inhibitor clinical trials. As I said, there are many more that have been either reported or ongoing in other populations because of some of the cardiovascular benefits that have been observed thus far. Next, and so you can see then these plus signs are almost universal except for the last one. The Virtus trial with ertugliflozin did not identify a benefit in the composite outcome, again, which was a MACE event, major adverse cardiovascular events. However, there was a consistent reduction in hospitalizations for heart failure across all of these SGLT2 inhibitor studies. And across most of them, there were reductions in risk of progression of renal disease. Next slide. So how do we know then which drug to use and in which situation? Well, the guidelines will help us, and I did describe those a bit in the first ECHO lecture or didactic. But this is also, I think, of some use. This is a meta-analysis of the CV outcomes trials to date. This was as of 2 years ago, so it's already sort of out of date. But you can see that for 3-point MACE, in this meta-analysis, there's a similar reduction across GLP-1s and SGLT2 inhibitors. For non-fatal MI, probably similar. What's interesting, though, is that there has been a reduction in risk of stroke observed with GLP-1s, but there really isn't any signal for SGLT2 inhibitors. So my suggestion would be if the patient's clinical picture is most consistent with stroke, then maybe consider a GLP-1. And heart failure or renal disease, then SGLT2 inhibitor. Next slide. And then here's cardiovascular death, which there were similar, maybe more favorable reductions with SGLT2s, and similar for all-cause death. Now, hospitalization for heart failure, it turns out you do see a small statistically significant signal with GLP-1s, but clearly much more benefits observed with SGLT2 inhibitors, and now we have data that has been done in patients with heart failure. And then this is the renal composites. And again, you see this very small benefit with GLP-1s, and that's much more established with SGLT2 inhibitors. And this is just real quickly what we discussed the first week. So just as a reminder, our ADA standards of care, starting with metformin, looking at whether a patient has atherosclerotic cardiovascular disease. You can use either of these classes of agents. If heart failure predominates, particularly if it's a low ejection fraction, then an SGLT2 inhibitor with proven benefit. In particular, empagliflozin and dapagliflozin have shown benefit in dedicated heart failure studies. If the patient has chronic kidney disease plus albuminuria, the evidence is strongest for SGLT2 inhibitors. If not, there is good evidence for reduction in MACE outcomes or cardiovascular outcomes with either class. I would still personally favor going with the SGLT2. And we'll go through the rest of these steps. And then if you use 1-8 class and there's no benefit, or the patient still has not reached target, then yes, you can certainly add another class. either GLP-1 or SGLT2 or any of the other agents demonstrating cardiovascular safety if the patient has known cardiovascular disease. And then if not, then you would go over to the right side of your screen where we've kind of thinking about other compelling indications for treatment. And that's what we discussed in the first week. So what about the Medicaid formulary? How does that fit into the picture? Well, I've just tried to simplify this a little bit here and just kind of put the actual drug names. So we've got dulaglutide and liraglutide that are currently on formulary, and empagliflozin, and a reminder for everyone. And then of course, if they're not at goal, then you kind of recycle and add on. So what about insulin therapies? Well, first off, when we're thinking about injectable therapies, you want to go with a GLP-1 first. Now there is an oral GLP-1, but as we discussed, it's not actually on the Medicaid formulary. I personally don't have a lot of difficulty getting patients to take a GLP-1. The GLP-1s, if they're not adequate, then one consider adding basal insulin. There are a couple of exceptions in those two circles at the top. You would consider initial insulin therapy if the A1C is markedly elevated, or if you think the person might have type 1 diabetes, or if the patient is markedly symptomatic. You might also consider a combination of insulin plus GLP-1 if they're not already on a GLP-1 and their A1C is well above target. So starting basal insulin in the purple box there, you would want to continue metformin plus or minus other agents, probably not the sulfonylureas or the rapid-acting secretagogues. I'd probably wean those off. You're going to start either 10 units per day, or you can do a weight-based dose of 0.1 to 0.2 units per kilo. Titrate that to the fasting glucose target. And also consider if their fasting glucose is not at target, whether there might be signs of excess basal insulin. This was sort of an addition to the guidelines this year. So consider if they're on 0.5 units per kilo already, really thinking about it carefully if they might need prandial insulin. If they've got a markedly elevated bedtime reading compared to their morning, you might want to start focusing on supper time blood sugars and or that postprandial differential. And in people who have a lot of variability, ups and downs, a lot of time that could be because they in fact just need prandial insulin. And then there are several titration algorithms for basal insulin. I think all of them are successful if you can get the patient to do that. I think that's the real barrier there. So oftentimes I would still recommend having them send glucose logs or setting them up with a nurse or a pharmacist to help them with the dose titration. And thinking about any causes of hypoglycemia. If it's not an avoidable cause, then a commensurate dose reduction of 10 to 20%. So what if they need prandial insulin? Well, consider a basal plus strategy. Rather than just throwing 4 shots a day on them, there's reasonable evidence that this strategy might be able to get a good proportion of patients to goal. First of all, a basal plus strategy, if they're not already on the one, if I don't sound like a broken record already, would be to consider adding a GLP-1 and or using a fixed ratio combination of basal insulin plus GLP-1. Now, I don't believe any of those combinations are on Medicaid's formulary. And then the next step would be prandial insulin, and consider at the largest meal. You can get about 50% of patients to goal with this strategy. Start with about 4 units per meal, or you can do a weight-based dose, or take 10% of their basal insulin dose as their meal dose. And if their A1C is reasonable or getting closer to target, you might want to cut back on that basal about 10% as well. Another option would be to use premix insulin. And then you can give them titration instructions if they're a very savvy patient. Again, I'm usually not very successful with getting patients to do that in clinical practice, but it works well in clinical trials. You can also identify the risk of any hypoglycemia, and education is very important in that regard. Next, so then if they're not meeting their targets, then you would want to expand out further to 2 or 3 meals. And I've got that little, warning kind of triangle there, hazard symbol, so that I can, point out that when you get to this point, that education, it's important probably at all of these stages, but you really want to be thinking about making sure that the patients understand how to do this well. And so why do I spend so much time on insulin? Shouldn't we be using non-insulin therapies? Well, it does turn out that over time, while insulin resistance tends to stay about the same in patients with diabetes, insulin secretion, or the secretory capacity of the beta cell, declines over time. And so this means that by 10 years, and certainly longer, most patients will start to need insulin therapy because of the chronic progressive nature of diabetes. So let's compare what the types of insulins that are available. So as you know, the older insulins, which glargine I would now put in that category, there are some significant differences. So NPH is your kind of intermediate acting insulin, does have a marked peak about midway, around 6 hours or so during the dosing periods. Glargine used to be considered a full 24-hour flat profile, but now we know it's really not quite a 24-hour flat profile. Dedamer in a similar way. They're more often tending to use dedamer twice a day than glargine, but in both cases, you can have a need for twice daily dosing. But with the newer insulins on your bottom 2 graphs, glargine U300, which is Toujeo, and degludec, which is Tresiba, in the purple and brown, you can see that there is additional flattening of that relative insulin effect, and the duration of effect is much longer now than 24 hours. In fact, there have been some studies that theoretically you could probably dose them every other day, but it's not recommended to do that. I think just having a regular schedule is really important. And because of this, you get several different benefits. So first of all, you don't ever have to give these newer basal insulins twice daily. They can be given once daily. The longer duration, because of their longer duration, there tends to be less hypoglycemia because you don't see that modest peak. It's more predictable, particularly overnight. Now, this is not dramatic, and most patients won't come back to you and say, oh yeah, I had a whole lot less hypoglycemia. But it can be a tool in some patients who have difficulty, particularly with overnight hypoglycemia. And then if patients start needing higher doses, these newer insulins are nice because of the higher concentration. So you're giving a smaller volume, and theoretically you might have better absorption. So how do we optimize basal bolus? So some of the things that I touched on already. First of all, review their medication behaviors or how they are taking their medicines. Simplify where you can. This gets very complex. If there are extra medications that they don't need, particular sulfonylureas, get rid of them. Use insulin-sparing therapies if you can. Keep their metformin going. You can use a GLP-1. There's lots of great data that those two agents work great together. Also, less so, but there's reasonable data that using an SGLT2 or a GLP-1 in combination with insulin can also help insulin work better while minimizing side effects. Insulin analogs, particularly if there's significant hypoglycemia or concern for hypoglycemia, although there many patients can use regular insulin and NPH effectively. Ultra long acting insulins, again, if you're still having difficulty with hypoglycemia. Concentrated insulins, I'm finding that U500 regular insulin I'm having to use less often now because I do have more concentrated versions of Lispro, glargine, and degludec, which are more physiologic. But I have used those. I would suggest if you're having to use if you're thinking about U500, that you probably want to refer them to an endocrinologist. And then also think about delivery mechanisms. There are smart insulin pens out there. If patients really do need to have intricate dosing regimens, that could be one way to help them because it helps calculate the dose for them. Inhaled insulin I've used very rarely, but for those patients with the most severe fear of needles. And then finally, CGM. So CGM is an important tool to think about in patients, particularly when they're needing more than one injection of insulin per day. And these are the different options available to you. The duration of wear time is a little bit different. All of the devices can be downloaded, although some with more ease than others. The ones that operate off of a cell phone it's definitely more easier to get data from, particularly if you're doing remote monitoring. And then education is just really critical. That patients have to understand the limitations of the measurements and when they need to do a finger stick. So for example, if their glucose is low or they're changing quickly in particular for any reason, they should get a finger stick. And then these are some of the metrics in terms of the time and range for patients who are using CGM that you should be thinking about. So these equate to an A1C target. So in the far left bar, the time in target range should be about 70% or more in an otherwise healthy individual without severe hypoglycemia or a lot of comorbidities. And that's with less than 5% hypoglycemia. Most people with type 2 diabetes can get well under less than 5% hypoglycemia. And then the balance in hyperglycemia. And then you can aim for somewhat more relaxed time in target ranges for older individuals, persons with more comorbidities. There's also pregnancy guidelines. And then in terms of interpreting your report, this is sort of a standard illustration of what the ambulatory glucose profile looks like. It's really just providing both your median by time of day in that orange line. In the blue, it kind of shows where the patient is spending about 75% of their time. And then in the green is where the patients are spending about 10 or 90% of their time. So it helps to identify patterns. And so that is one of the things that I try to emphasize quite a bit with the patients is look at patterns over time and try not to focus on just one day or one time where you know you did something wrong. Let's see if there are patterns that we can make adjustments with. And then again, getting back to this whole telehealth world, I think we're going to see more and more connected devices. I won't spend a lot of time on this, but this will be the road of the future. And it is a challenge because many of our patients don't have the connectability that we need them to have to really be able to do this well, but optimistic nonetheless. And then I did mention briefly the smart pens. This is one example, the InPen, that you can actually set up if a patient can count carbs, you can set up a carb ratio, you can set up a correction formula. So if their glucoses are high, it can calculate an extra dose for them. Or it can just do a simple, here's what you take at breakfast, here's what you take at lunch, here's what you take at supper. So there are many ways to do the dosing with the help of the app. And then when the patient does give a dose, it gets recorded back into their phone. So I'll stop there and we'll take some questions. Feel free to, again, put some questions in the chat.
The question out there was, what's been your experience in starting insulin and with the newer therapies? And my question to Kathleen actually was something I think she's very well qualified to answer. The ADA is still recommending sulfonylureas and TZDs as a more cost-effective option if you look on the third part of one of her slides. And I noticed that too, and that was really surprising because I've been trying to get people off of those medicines for the last 5 or 6 years or so, and it's not easy. They want to be on their glyburide and Amaryl and things that are really out of date. So Could you comment about that, what the rationale is for still recommending sulfonylureas and TZDs?
Well, certainly cost is a major issue, and for patients who can't afford the newer agents, these drugs are still a necessity. The sulfonylureas are very effective glucose lowering, particularly early on in the disease course. It's just that they tend to lose their effectiveness more quickly than any of the other drugs that have been compared. So you do want to be mindful of that. If they've had diabetes for a long period of time, it's possible it's not even doing anything for them anymore. The TZDs probably don't get as much respect as maybe they should in some situations. I think many of us have become so scared of using them because they do cause weight gain, and they can increase the risk for fluid retention, which can increase the risk for heart failure. But they are also very effective glucose lowering agents. I would just use the lowest dose if you can, and certainly no more than 30 milligrams to minimize some of those side effects.
Thanks, Kathleen.
So Kathleen, I noticed one of the questions from Krita Aurora asked about discussing the side effects of SGLT2 inhibitors and how best to counsel patients. And we've had that question come up before. So I thought people on the phone may have suggestions besides you if they want to chime in, but I think that's, how people are counseling patients when they start SGLT2s and GLP-1s, I think can be useful to hear.
Yeah, so my general approach is to focus on what's going to keep them on the medications. And so I definitely want to address the most common side effects first. And I always give them, kind of a written, maybe more simplified list of considerations to think about, to take with them. And if I know ahead of time what my plan might be, and maybe the patient isn't quite ready to make that decision, I'm going to give them that information to think about, and then have them say, come back, and that would be a perfect setup to have them, come back with the nurse or the pharmacist to kind of, actually implement the plan. So it's not always done, just, okay, you got to do this right now. So and it does take a lot of time, I think, to do it well. So this shared decision-making approach. So in terms of the really rare side effects, I don't spend a lot of time on them. I do let them know that, yes, there are some very rare side effects that can be seen, for example, pancreatitis. There's still this question as whether it might increase the risk of pancreatitis with GLP-1s. For SGLT2 inhibitors, there's, maybe some concerns that it could, increase the risk of, there's this question if they can increase the risk of amputations or fractures. The thing is that all these really rare side effects aren't really well established in the literature, and it's about trying to help the patient understand the potential benefits versus the risks. And that can be really hard because, as we learned, I think a couple of weeks ago, patients don't always understand, risk-benefit ratios. They don't even often understand percentages. So if they have questions, I encourage them to reach out to me. But I try to have them focus on just the most common side effects. And, for SGLT2 inhibitors, it's polyuria polydipsia and yeast infections. And I tell them, if you get a yeast infection, just send me a MyChart message. We'll get you on a diflucan. If they have nausea, I try to give them a pretty regimented or a set of instructions on how to maybe mitigate that, and then tell them that these are expectations that can happen. They don't necessarily mean that you have to stop the drug. Well, I think we're ready to move on to the case now.
We did a famous experiment when I was back in Pittsburgh. I sent one of a student wanted to do a research project to go and have lunch at a fast food restaurant versus his lunch at home, and compared it in terms of how long he's waited in line, how much money he spent, not to mention forget nutrition and quality and all those things out. There was no contest whatsoever. main driver of fast food is taste, number one. Taste is the number one thing. People like it. So really kind of making that clear to her and saying, yeah, I know you realize that McDonald's might be a convenient option, but how do you feel about the food? Do you really enjoy it? And can we steer you to try new novel foods that might substitute it? And not worry about arguments about convenience and, oh, it's cheap, it's available, it's easy, which is not true. It's been shown over and over again. That might be something, it's challenging for people to accept that. Mm-hmm. Is the primary driver. That's why they're so successful.
Thank you for sharing this case. I just have a couple of clarifying questions about her mental health status. And I'm just wondering if you could describe, the extent to which she's sort of in regular psychiatric care. Does she adhere to her mental health care regimen? And when you see her, does she present with any sort of, with a particular psychiatric symptom profile?
Yeah, so yeah, absolutely. So that is a big factor in her care. Every time I see her, she's always in some type of a distress. She has a lot of social factors, a lot of family issues. She does seek regular mental health care, and she is on medications, but this last visit, she took herself off of them because they weren't working, per her report. So yeah, that's a huge factor. So she's always in crisis. So to try to refocus her back is very challenging.
So I asked that because I was part of a large randomized trial of sort of joint self-management, peer self-management of both diabetes and serious mental illness. And one of the more anecdotal findings there was just that the diabetes management really followed the mental health self-management, and that sort of like to be able to open the door to better glucose control and lipid management and blood pressure control. The folks who seem to have the most success with that were the folks who managed to maybe not sort of completely solve all of their mental health challenges, but at least they were able to demonstrate and feel some progress and some confidence in their day-to-day mental health symptoms.
Mm-hmm. Yeah, we do have what we call BH consultant on site, who typically every visit will either sit in with me during the visit and try to help redirect or see what he can do to assist her with her mental health issues. He definitely sees her after I see her and tries to offer support as well.
I think that might also play a role in some of the kind of the nutrition counseling pieces. One is if she's always in crisis, it's the meeting the primal needs at the time as opposed to the other. And then even if if the conversation focuses more on the weight management side than it is on the diabetes, it's probably hitting more of the struggling side as opposed to the opportunities that she could be taking to manage her blood glucose, but then also would probably result in some weight management changes. But if the focus is on the weight management, it's probably a more frustrating conversation. So probably some of that communication, she probably asked the dietitian probably asked the patient, what's your goal? Why are you here? And she said, to control my weight. Whereas the broader concern is around that. So kind of getting on the same page to start might help.
Mm-hmm.
Yeah, and because her fiance is also interested in weight loss, apparently, and he's losing weight. And I know this patient is on disability, so I don't know if she has a physical disability, but the sedentary lifestyle could be addressed perhaps by having them do some physical activity together routinely, and wouldn't focus on so much on eating habits as just movement and physical activity, which also helps a great deal with mood. So I wanted to see kind of what your thoughts were about proposing that they get some physical activity together and whether she'd be able to do that with her disability.
Yeah, so it is just mental. She's fairly active. I mean, she's physically capable, and we have talked about that many times. You know, it's hard because it's winter, so they don't want to go out. She lives in an apartment. I think it's on the 3rd floor, and she feels that that's her activity. It's hard enough to go up and down those stairs every day. And so, you know, I try to talk, you know, maybe you guys could go to the mall and mall walk and people watch. And that's hard because they don't have any money. She doesn't drive. He has the car. And every time they come and see me, we're always giving them a gas card because they can't afford to drive anywhere else. But we do talk about that. I do try to, you know, suggest that.
You know, and I don't know if they have internet access, but a lot of our patients in the Fit or Me weight management program are doing, especially with COVID, they're doing YouTube videos, which are free to exercise videos, and there are thousands of those at all different levels. So I don't know if that would be an option. And there are many just body weight exercises and things that can be done without even leaving the apartment. And strength training does help significantly with weight loss, building more muscle, increases metabolism, and helps with weight loss. So those are just some options too.
Thanks.
And she does technically meet criteria for bariatric surgery. That can be a challenge in someone who has untreated mental health, and
Yeah,
that's often a contraindication. So
yeah, I don't think they would approve her because of her mental health. I have thought of that. Anything different that you would do with that diabetic medication regimen that you could suggest?
Hi, this is Komal. I'm one of the newish attendings. So what I had learned during my fellowship was that after the 50 units, the Lantus or, you know, one of the longer actings, they don't get absorbed much. So what I was told was after the 50, you tend to like divide and see if it get better absorption. So she's on like 80. So maybe like dividing into 40 and 40 might help her absorb insulin better.
well, she's on U500, right? Yeah. So
The endocrinologist put her on that.
I mean, I have seen regimens with Lantus used because occasionally the U500 really just wears off, that supper dose wears off overnight, and they need something to carry them through the evening. So the other thing you might think about is if they really need that, first of all, trying to optimize the supper dose to make sure they're going to bed at a reasonable number. But sometimes you could also just add a tiny dose at bedtime. So that way, at least it's not 2 different pens that they're having to use. And then you can get around the absorption issue too.
Okay.
But it's not that common, honestly. I mean, most people on U500, you usually have them on just 3 shots a day, occasionally even 2. So
Kathleen, you're saying that when they're on U500, you actually remove the Lantus and you just use the U500?
usually, yeah.
So
Harry, has she been going up steadily on the Lantus, or has she been on the 80 units for a long time?
no, she's been on that for a bit. Yeah. So would you say would you try to divide the Lantus, or would you try to just take her off and try to optimize the U500? I got confused.
Well, yeah, there is no cookbook for this. I mean, my preference would be to actually see what her glucose levels are, see what her supper time glucose or her post supper glucose readings are. If she's on a Libre, so I mean, this would be really nice to be able to see patterns. I'd try to optimize that dose. If she needs more supper time insulin, and then take her off of the Lantus.
Okay.
You could split it, but then you are getting more injections. And then the other option is, if they really do need it, is you could do Glargine U300 or Degludec U200. I think I would still give that as a single injection. I don't know. Kamal, what do you think? Is that Kamal?
What I learned was when the absorption gets an issue, you do switch to 500 at that point. So I have not seen the U500 with the long acting, to be honest. Like, it was mostly U500 with carb count. So if the patient could do carb count, that would be an additional, thing that you could teach them.
Okay.
Yeah.
Does it matter with U500 and the long acting around weight? Once they're on insulin, it's just harder for people to lose weight. And obviously there's the weight gain as you're titrating up the insulin. So I don't know if there are differences in terms of trying to get, if she's trying to lose weight, is there anything that you guys would recommend related to the insulin and that?
That is the one thing with, carb counting is really hard for most people to do, but that is the one potential, theoretical advantage is it could allow them more flexibility so they're not eating to the insulin. But, to be honest, the randomized controlled trials that have been done in people with type 2 diabetes, comparing fixed meal doses with carb counting are kind of, underwhelming. They definitely see much more benefit with type 1 diabetes, but it just depends on their level of motivation and understanding. I mean, maybe you could do fixed big meal, small meal kind of concept as well.
How about going up on the triglyceride to 3 grams a week?
Yep. Yep.
If she can tolerate it, GI wise, I think we could try that.
So I'm going to be seeing her soon. So would you suggest trying to go talk to her about going up on the triglyceride?
If she's able to tolerate it.
Yeah. And try to take off the Lantus. I'm not saying I have to do this all at once, but take off the ultimate goal would be trying to go up to the 3 grams, taking off the Lantus, and then just maximizing the U500 3 times a day. Okay.
Yeah.
And I would just also really be careful in asking about how often do you miss a dose, or how often do you skip a meal and therefore miss a dose. Those things are oftentimes hard to elicit, and they won't volunteer it.
Right. Yeah. And she doesn't always bring the Libre in, so hopefully she'll bring it in this time.
Well, great. So we are at the top of the hour. So I'd like to send it back to Jessie for our wrap up.
Great, thanks. All right, so first, we just wanted to give you a notice. We wanted to send out a red cap form to all of you. This just collects kind of updated contact and demographic information. This way we can let you know about future opportunities or updates. This information would just be shared among our leadership team for internal program evaluation purposes, and all data is always presented in aggregate. And then the other thing that we hear from participants is that they like to share a contact sheet at the end of the series. So that way you all have each other's names, emails, practices, so you can continue to use each other as a resource. So I will be putting that together based on the information that you put in this form. If you wish to opt out and you don't want to be listed on that form, please just email me and let me know, and I can take you off the list. And we're looking for you to fill this out by February 18th, if at all possible. Just the usual reminders. Don't forget that you can watch the recordings of this current series on our website, cardio.org. If anyone is having trouble registering for an account on there, again, please just email me and we can make sure that you can see those recordings. And then you should have the post-clinic survey in your inbox for today's session that will be closed by 5 p.m. tomorrow. So fill that out when you get a chance. And then the last thing is just a reminder that next Wednesday, Cardio is hosting a webinar on integrating behavioral health and primary care services. This is from noon to 1, it's free to attend, and CMEs would be available. You can find the registration form on our website. So with that, I know we're just a hair over time, and hope everyone has a great rest of their week.
Thanks, everyone.
Thanks, everybody.